Hello, Harshad. 음. Testing, 1, 2, testing. Sure.
Muchísimo nervio has hecho.
Hi, John.
Hello,
Hello, Said.
how you doing?
Fine, and you?
Here, let me get off this pen. How you been?
Fine. We start at what time?
We start in about 10 minutes.
10 minutes, okay.
Do you have any French speakers yet?
French speaker?
French, yeah, do you having French speakers for the French neurosurgery grand rounds?
Yes, it's we come back. Yes, we come back soon.
Well, just let me know.
Okay.
Here's Vlad. You know Vlad, right?
Yeah.
Here's Vlad. Are you there, Vlad?
You just need to start the thing. Hello,
There
John.
you go.
Good to
Where'd
see you
your books
again.
go? Where'd your books go?
No, ma. Always.
Oh, you sold the books, and now you're
Yeah.
all computers.
Yeah, sure. I have two computers and one of them didn't work. But this one does. So I hope everything will be okay. How are you doing, John? How's Miami?
Good, good. It's nice and hot. I like it hot.
Me
And
too.
very, very sunny. This is the hottest time of year in August, September. And this is when the hurricane come too.
Does it?
We
Yeah.
might get some hurricanes this year. We usually get them in September.
I see. So we have some fun at least.
Yeah, they can get pretty bad. The worst one was Andrew, Floyd. Wow, but that was
I
10
remember
years
the
ago.
one.
That was 20 years ago. But I still remember it. Wow, unbelievable. I've never been. Have you ever been in a storm? A bad storm?
Not that kind. Not that kind of storm.
Wow,
Never.
it's incredible.
Never.
The wind.
I only
200
failed due to the storm. I failed my driver's license in Arizona because there was a question: what do you do in a sandstorm? Stop immediately, drive slowly ahead, or drive no normal way. So I did,
Arizona.
there was something surprising for me.
Did you go to Barrows? Did you go to Barrow?
What?
Would you
Barrow,
go
Barrow.
in Arizona? Barrow?
Barrow.
Oh, okay. You like it there?
Spencer was still at his heights. It was the best year for me. Long
good.
vacation.
Yeah, Arizona's incredible. Did you go to the canyon, the Grand Canyon?
Sure.
That is incredible. You'll
Beautiful.
never see anything like that in the whole world.
No. Well, you see the deserts like that, you know, the painted desert in Arizona, the same thing is in China, the same thing in Kazakhstan, the same thing in Pakistan, these painted deserts, but the canyons are not there, you know, the canyons are very specific. And monumental only, of course. It's definitely something which is only in Mexico.
It's a dangerous place. You got to really watch yourself.
Yeah, you do. You do.
You got to know what you're doing.
So whom do I talk to? To Chinese?
Yes, it's mostly Chinese neurosurgeons, between
Right.
500 and 1,000, depending, because Medtion is very good to us. They're televising this now and translating it in Chinese. Hey, let me show you. Let me show Saeed also.
Professor Benes, nice to meet you. Doctor, nice to meet you. I'm a neurosurgeon from Rhino Island. It's a French overseas department in Ocean India near Mauritius.
Ah,
And yes, and I'm also a friend of Pablo Gonzalez and all our friends of 3D Neurosurgical TV, the 3D Neurosurgical meeting in Alicante.
very good, very good. I've been to Alicante several times. Pablo is one of my best friends. And Maurice Chu, I haven't seen him over the past year or two. Is he still doing well?
Excuse me?
Maurice Chu, I haven't seen him for a long time. You mentioned his name. There were
Yes,
two of them. Maurice
yes,
Shu and
Mauritius
Constance.
it's an independent country, and near it's about 25 minutes by plane. There is Réunion Island, La Réunion. La Réunion. It's in French, La Réunion. It's a French department in the Ocean Indian, and there is another department over Madagascar in Comoros. That's its name is Mayotte, and it's a second department in Ocean Indian. So there are two French departments. And we have department of neurosurgery, and we do all operation, and we cover all the region of Ocean Indian and the south.
How do you get the patients? By plane?
By plane, yes.
By plane. What is the population?
It's about 1.5 million.
That's good. That's good. Must be fun in such a place.
That's very fun, and I plan to do an international congress in 2025.
Count me in.
I hope if you come, will be with us.
Sure.
It will be a great honor to have you. So I send you my mail address, and
very good.
Yes.
Very good. Very good. We could offer a seminar or a session or a course by IANA, this International Academy of Neurosurgical Anatomy. Pablo Gonzalez is one of the main people there, and we enjoy spreading knowledge. We enjoy the fun. We enjoy this. So anytime.
Yes.
Anytime.
Yes. Okay. Well, yes, Pablo Gonzalez is a great friend of mine too. With Samir Baba, Stamparius, and all the team, the friends. There is a long list of neurosurgeons. But this year it was a great because we had about 73 participants, and from Australia, from United States, from Europe. It was a great congress. Yes, I hope that next year.
Next year, anytime.
Yes,
sure,
yes,
for sure. Yes. You have some contact to me, mail or WhatsApp?
Yes, I will send you my mail address.
Do so.
I do it in the.
Yeah, now. We shall keep it definitely in touch. It's very tempting, and yes. It's an honor to be a guest in such a place.
Yes, it's an honor for
really,
us.
Yeah, it's really pleasure.
Yes.
Yeah.
Yes. I send you my mail address.
Yeah, sure. With pleasure. With pleasure. John, they are going to translate the lecture, or are they going to understand?
Yeah. The people that come into the webcast, they usually speak English.
Good.
And the Chinese is translated into Chinese. You see the person on the panel? It's brainmed.com. Yeah, it's a big website, a video website in China. They translate also into Chinese, from English to Chinese.
Right. Because we always had problems there with the language. Whenever we were there, it was really difficult. Only few of them, and the webinars were always somewhat, let's say, restricted by the language. But they watch the YouTube. I checked what we as IANA have with our webinars. There were 60,000 hits on YouTube on the webinars, which is extraordinary, and there was quite a lot of from China.
They
Quite a
have
lot.
a huge library of neurosurgery videos.
Yeah.
Huge. And just wait till AI gets a hold of them.
Yeah.
Artificial intelligence. Because language is one of the first things that's going to be improved.
That's true.
It's getting really good. I mean, the translation in real time of language is getting really good.
Is it?
Within like 3 or 4 years, we'll have immediate real-time translation
Very good.
in probably every language.
Oh, you mean not only Chinese, you mean other languages as well?
Any language. I think any I would say within 5 years, any language
Good. That's good.
will be translated immediately in real time. And of course,
Very
it's going to make webinars very relevant because they can get to the whole world with
course.
the video.
Of course.
Potentially.
The consequence of the COVID, which really changed everything, you know, they sit at home, do not pay the flight, do not pay the hotel, do not pay the fee. It's extraordinary.
Yeah, the world in 5 years, the world's going to be a lot different.
Yeah, that's true.
Different.
That's true. That's true. But one only wonders whether it's worth to survive that much.
Yeah, if we could just make it that far. It's a crazy time with our President Trump and all this crazy stuff happening. It's a crazy time in history.
It's crazy.
It really
crazy.
is.
US is crazy now. That's true. That's
it's insane what's going on now in this country.
But I don't think Europe is something reasonable. It's not. We have this Green Deal and we have the war. So it's not really that a big fun here.
Yeah,
anymore.
It's getting serious there too, right?
Yeah, it's same thing as in US, you know, that everything is getting different.
Yes.
Yeah.
Excuse me, Vlad Wan Lee, how are you doing? Good morning.
Hi, yeah, John. Yeah, I'm fine. Yeah.
Okay, you met Vlad, right? Vlad Benes, the main.
Yeah, we've met. Hello, Angli.
Hi. I think Bing, she still in Istanbul or returned Shanghai. I'm not sure.
Nor me, but we definitely met.
Okay, yeah. Bing, she Bing. Yeah, she Bing here.
Is your speaker here? Is the speaker here? Your other speaker here?
Bing is online. I guess he want to be the.
Oh, there he is.
Bing already.
Dr. Zhang, right?
Yeah.
You let him get in. And Vlad is going to speak first, right?
Right.
Okay.
John, like 30, 40 minutes, you said, or?
Okay, he's on his way in. Okay, you ready? Ready, Vlad? Let me introduce you first, okay? 10, 9, 8, 7, 6, 5, 4, 3. Good morning. This is Dr. John Bennett broadcasting from beautiful Miami Beach. Here in the background, we have our regular bi-monthly China Neurosurgical Journal webcast. We have a couple of presentations today. And one of them, let me introduce Vlad Benes. He's a well-known Czechoslovakian neurosurgeon, as well as, I'm sorry, I said that wrong again, Czech Republic.
25 years ago, the country split.
I gotta go back to geography class. Anyways, Vlad is a great guy. He loves to do webinars. During the COVID, he did a lot of webcasts because we're all stuck in our house. So, okay, Vlad, welcome, and it's all yours.
Welcome. I share the screen.
Yeah, today we have two speakers. Please, Vladimir Benes from ZAC we'll talk about supracerebellar infratentorial approach. And then Professor Zhang Xiaobiao from Shanghai Zhongshan Hospital will talk about the endoscopy surgery.
Oh, good, good, very good.
Yeah, I think Professor Zhang is also online right now.
Okay.
Vlad, you want to put it on presentation mode?
Is it seen, John? Is it all right?
No, it's small screen. You can see it, right? Can you
I
put
see
it
normal.
on present at the very bottom on the right-hand side? You've got to click on one of those icons. You see the bottom there?
Now I have the regular presentation on my screen.
You see the bottom right? The bottom
Yeah.
right is on your screen. You're going to click on one of those
I
icons.
put new share.
Yeah.
Again, the lecture.
Okay, you see at the bottom right, there's 4 icons.
I have another mode probably because on my screen I have the regular presentation in presentation mode.
Okay, well, keep experimenting. You haven't got it yet.
Sometimes it takes us a few minutes before to have it in full.
Wait, stop the presentation. You now see the lecture in a small.
No, click on the screen, any screen. Click on the screen, click on it. Open the slide. Okay, there we go. Now go to the bottom and you need to put it on
Presentation mode. Is it all right now?
No,
Not yet.
not yet.
I don't understand it because on my screen everything's all right. So once again, I shall click on the big one. You now have the small slides, don't you?
Yeah, well, you've got to make an adjustment. At the bottom of the screen, there are 4
The
icons.
bottom of the screen, the icon for presentation
Yes.
mode.
You can't see
If
those
I
icons.
hit it, I get a normal presentation on my screen. But
Well,
you do
okay,
not get it.
Vlad, okay, just click on, okay, it's fine now. Just click on every slide. That's fine. That'll
Is it
do.
fine now?
Yes, that's fine. Go ahead.
Okay. So thanks for the invitation. It's a great pleasure and always exciting time with these webinars. And at this time, I've got the task to talk about the supracerebral infratentorial approach, which is my favorite and which I really love over the many years. This is a series over the past 15 years. Definitely, we started with spinal cysts, which is a very obvious diagnosis to learn the approach. But majority of patients now are meningiomas, brainstem cavernomas, gliomas, spinal tumors. And I will show you the capacity of this approach because it's not only the pineal region. Of course, at the beginning, not everything needs surgery. On the left, you see the pineal cyst. In the middle, there is a year after.
Excuse me, Vlad, you're still on the first slide. You're still on the first slide. You're going to have to change them manually.
I'm proceeding normally.
Yeah, you're still on the first slide.
Okay, so I shall stop this presentation and I shall go like that. Is it all right now?
Yes, now you see the CT scans. I mean,
Yeah.
All right, so
Is
is it understandable and seen as it?
Yes, yes, it's clear.
Yes, okay. So here you see the pineal cyst, which we never operated, and the cyst disappeared within 2 years. So always we are careful with them. The limit of the approach from a superior point of view is the position of the vein of Galen. As soon as the lesion is above the vein of Galen, like here, this colloid cyst of the third ventricle is above the vein of Galen, then another approach is called for. On the other hand, anything which is below the vein of Galen can be accessed with this simple approach. This is the anatomy of the approach. Left is roton, right is our surgical view. You see vein of Galen, you see the internal cerebral veins, basal veins of Rosenthal's, and the tentorium, which using the midline approach is very steep and it's quite far. So over the past 10 years, I never did bilateral, always unilateral supra-infra, which is shorter, not that steep and much more easier. This is what we've published on pineal cyst. that was our interest for many years, and we probably exhausted the topic. So unilateral only, we use the sitting position. The sitting position is some fear for neurosurgeons, but at our institution, we use it for schwannomas, we use it for this approach, and we didn't have problems. You need a good anesthesiologist, you need cardiac echo to monitor the patient, and we just use it very, very regularly. TSF drainage, the lumbar drain, in my mind, is probably the best invention in neurosurgery. We start with draining some 20-30 cc. I soon will show you why. Craniotomy must be well above the transverse sinus, because by stitches you lift not only the dura, but also the transverse sinus a little superiorly, and any millimeter here is very important and gives you much more space. The dura should be opened along the sinus, no more than 15-20 millimeters below the transverse sinus, otherwise the cerebellum will prolapse out of the opening and you have the problem. So it must be really nearly parallel to the sinus. And tentorium incision, as I will show you later, is called for in certain cases. Both microscope and exoscope can be used, and you see that the exoscope is a little better because it's much more ergonomic. You do not have the extended arms like you have with microscope. This is really not surgery and position for the surgeon with short hands. But with exoscope, you can manage easily. We now put the screen above the patient's head, so everything is in axis and there is no problem at all. And the view you get is excellent because you can put the head of the exoscope underneath your arms and then you see much better above. So this is the radio roll. Craniotomy, you see the rectus sinus there. And this is when dura is opened and 20 cc was drained by lumbar drain. Immediately the cerebellum is giving you space to get as far as tentorial incisura. There are several ways how to look at this.
मित्रांनो कालच की दुरातनं मला ब्रेथ घेऊन साप सोचको पाठवतो त्याला वाटे नष्टा वाटतं सर.
Okay.
I'm sorry. Okay, go ahead.
Okay, good. So in my mind, I have divided the approach to medial, which is anterior, superior, and inferior. Anterior would be pineal, superior would be posterior thalamus. Then you need to cut the tentorium, and inferior is mesencephalon and upper fourth ventricle. I will show you the examples. Then lateral, when you go more to the sigmoid sinus, again, anterior, superior, inferior. With anterior, you access the pyramid apex for all the meningiomas and similar lesions. With superior, you reach the upper tentorial edge. Again, in this case, tentorium must be incised. And inferior is for upper pontine lesions like cavernomas and things like that. Then there is superolateral, where you cut the tentorium and you reach the medial temporal and occipital lobes. It's an excellent approach for epilepsy, for instance. And then there, of course, is combination with retrothic and paralateral and combination with falcotentorial approach when you need to get above supratentorial. So let's go through each of them. Medial, anterior. I don't think the videos will play now. John, can we do something about that? I'll get back to the presentation mode.
Mm-hmm.
On my screen, the video is playing, John. It's not
Okay.
on the
You
screen.
don't see it.
Do you see it or not?
No.
No, it's not. It's frozen. Yeah.
This is a pity because it will be
Perhaps
without
your
video.
connection is not good, strong. So
Probably. So let's get back to this. So this is the site you see when you go for pineal cyst. In the middle is the vein of Galen, and then it's always better to start more laterally in the ambient system, cutting the arachnoid. The arachnoid here is dense and very, very strong. So one must really use scissors mostly to cut the arachnoid. And the only vein from posterior which is to be preserved is that cerebello-mesencephalic vein, which is very tiny in the midline, but it's easy to avoid it. So here's the ependymoma of the posterior side ventricle. Excellent approach for such a tumor. You see the post-op images. Terminoma, this was operated by mistake because the markers were not conclusive. You see before and after, and you see the tumor on the screen. The meningiomas in these regions, two types. One of them is in the pineal system. Those are free of dura, but majority of meningiomas in this region are anterior rectus sinus meningiomas, falcodentorial, things like this tumor I'm showing you. Here, really, the approach is pretty direct. Net, very rare tumor in this region. Major pineal tumor, again, rare things. Medial superior, we are going to get higher to the posterior thalamus. So this is a lesion within the thalamus, the pilocytic astrocytoma. And if you use the supra-infra only, you do not get high enough to reach the cyst. And the cyst is exactly the spot where you want to enter the thalamus. So you cut the tentorium, very limited opening of the tentorium, and then you reach the cyst and the tumor. Now you see that we are on this image pretty high. Unfortunately, the video is not working, so I cannot show you how we did it, but this is the 6 months after the patient without any neurological deficit. And on this post-op image, you see where we really were, that we were deep in the thalamus, resecting the tumor radically. Another tumor like that before and after, again, cutting the tentorium is the most important step in this surgery. Cavernoma in this region, again, you will cut the tentorium. Here again, the video, unfortunately, will not play for you. I'm sorry about that, but probably really the connection is weak, as John said. This is after the surgery, and again, you see where we were, where is the cavity after the cavernoma. This patient, she had a 6 months lasting hemihypesthesia, which cleared over time, but otherwise she's the lady is intact. We have published these cavernomas first in the series of brainstem cavernomas, and then we did a meta-analysis of cavernous malformations, including these deep ones. And the conclusion is somewhat new, because we proved with this meta-analysis that radiosurgery for cavernomas is a very valuable thing. You cut down the risk of bleeding by 50%. And although that probably we are operating all those hemispheric cavernomas unnecessarily, because the risk is so low that we really do not change the natural course that much. On the other hand, deep-seated, like these thalamic, are to be treated aggressively. This is a very strange tumor. This is a pinealocytoma, and it's probably the only tumor where we had to enter the velum interpositum, which usually in meningioma is free of the tumor. Again, there is the video. This was my last bilateral approach. That was the exception because the tumor was so extensive. The tentorium was incised on both sides. And what you see here is the tumor. The tumor is here. And this is the internal cerebral veins going across and partly within the tumor. This is after the surgery. And you see that we really resected the tumor even from velum interpositum, from both ambient cisterns and from pineal cistern. Medial inferior means going down in this region. First is the AVM in the superior colliculi. You see the bleeding. You see the tiny AVM, which was diagnosed by targeted angiography, and the endovascular people refused to embolize this thing because they didn't know what is en passage, what is feeding the AVM only. So we did it the use by supra-infra. Again, the video is not there. This was the only AVM which was approached along the vein. There was the atypical vein, the draining vein of the AVM, and we went backwards using ICG and high magnification to cut everything which entered the AVM, and this is the post-op image with AVM clearly eradicated. This was actually the only AVM approached by this approach. Cavernomas, obviously the best indication, the very straightforward approach. The lower limit of this approach is probably the exit of the fourth nerve. You need to push the cerebellum quite too much if you go as far down as it. However, on the other hand, you can enter the upper fourth ventricle. In many hands, this would be telomeral approach. I thought that this cavernoma is too high for this approach, so we went from above. This is the mesencephalon here. Here is the cerebellum. And what I did was a short paravermian cut in the cerebellum, approaching directly the upper fourth ventricle. The cavernoma was excised without any trouble, and you see the only incision in the cerebellum, which is insignificant and which is completely without any sequelae. Lateral anterior, now we are going to the pyramid apex area. So we were talking now about this B and C lines. A is already symptoms or obsolete in my mind. And now we are going along this pyramid ridge, along the superior petrosal sinus to the area of lateral mesencephalon to the CP, upper CP angle and far beyond. This is the anatomical study we did. We are looking from below, and you see it here. Here is the pyramid apex. Here is the fifth. Here is the sixth. This is the temporal lobe. This is the brainstem, and you see the arachnoid as it is quite distant from the brainstem, distal to the fifth nerve, but at the fifth nerve above it, the arachnoid turns to the brainstem to join the sixth nerve, where there is the border between the cerebellopontine and prepontine system. And this is exactly the space where the meningiomas do not have a good dissection border. So this is the dangerous part. And you see that you are not that far from the basilar artery. This is other view from us. From posterior, you see the arachnoid covering the fifth and going down to the brainstem to get very close. We did these studies with specific technique, and here we published the lateral supra-infra with colleagues from Lausanne. This is the anterior limit of the supra-infracerebral approach, and this is the Lillienquist membrane. You see the cholesteatoma, and the cholesteatoma gives you the space, and you easily get to superior cerebral artery, which is one of the most important structures here. And then there is the posterior clinoid, and obviously the Lillienquist membrane, which keeps all the tumor. You do not see the meningioma going through the Lillienquist membrane. They always has it as the border. So this is one of the pyramid apex tumors. This lady is 32 years. She's 6 months pregnant, and the tumor decompensated. So we had a lot of discussion with the obstetrician. Finally, we persuaded them to operate on her being pregnant. We did it. You see that after the surgery, we left a small piece behind in cavum meckelli. And this is during the surgery. Again, video doesn't play, but this doesn't matter. This is the origin of the tumor. Where is the entry into the cavum meckelli? And this is the third nerve. And this is the Lillienquist membrane, which is really forming a border for the tumor. This is the mother. This is the son of the patient who spent with us some 6 hours of his very early intrauterine life with us. Here's a schwannoma. Fifth nerve schwannoma is obvious indication if there is more volume of schwannoma within the posterior fossa. You see that we resected the part which was in the posterior fossa. We left behind the cavum meckelli part because the patient was like 72 years old. And we saw that some extensive surgery is not really called for. And this small piece may be easily treated by radiosurgery, but it's stable after the surgery, so we did nothing. Going lateral inferior, just another avenue, and that is the upper brainstem. Upper brainstem cavernomas mostly. You see the lesion here, and you see that it's directly adjacent to the tentorial edge, to the tentorium. So this is the place where one needs to get, which is rather easy. This is the MR day after surgery. Another one, the very little tiny piece of the cerebellum needs to be pushed downwards to reach the cavernoma. In these lesions, the lowermost part of the lesion is rather difficult to access, like that was in this pilocytic astrocytoma in 8-year-old boy. You see it now. You see the image when we get there. This is the fourth nerve. This is the superior cerebral artery, cerebellum, tentorium, and here is the tumor, which is being resected, keeping all the arteries going to the brainstem, which runs through the tumor intact. And this is at the end. And you see that the approach really is very easy. This is all you need. The cerebellum by gravity is pushed downwards. So you see the resection. This is the lateral part of mesencephalon where the tumor was resected from. And this is the top image in the boy. And you see that in the lowermost part of the tumor cavity, there are some smaller remnants, but since this is a pilocytic, it keeps stable. Meningioma is quite most frequent target of surgeries here. This tentorial, or someone would call it petroclive, whatever tumor easily accessed from here. This is the video, which again, unfortunately doesn't work, but you will see that without any retraction, without any problem, you expose quite a lot of the tumor, and just by using CUSA, decreasing the size of the tumor provides you with the space, which is all you need to resect the tumor. Lateral superior, should we need to go higher? These are the tentorial edge meningiomas like this. You see that the tumor is directly in the ambient cistern or pushing the arachnoid of ambient cistern. This is after the surgery. And this is the local anatomy from our dissections. You see the tentorium, the tumor has its origin somewhere here. So we are going to deal with ambient cisterns, where is the fourth nerve, and with the crural cistern, where there is choroidal artery and basal vein of Rosenthal. This is the video, and this is the image after. You see the Rosenthal vein, you see the fourth nerve, and undamaged arachnoid of the ambient cistern. And what we look at is obviously mesencephalon. Large tumor like that, but again, the same approach in the post-op MR. This was somewhat more difficult. This could be called sphenopetroclival meningioma. It's an interpeduncular cistern on the lateral side of the brainstem. It has a small extension subtemporal, and the tumor is in the CP angle. So let's see what we see. There are 4 steps in this test. The main bulk of the tumor in posterior fossa is resected. Then the V-shaped incision of tentorium ensures just medial to the tumor and just posterior to the fourth nerve entry into the cavernous sinus. Then the part which is in the subtemporal region in middle fossa is resected. And lastly, the interpeduncular cistern is addressed, and see what you see, starting with the 7th, ICA, and 5th nerve. The tumor is resected from here. Then it's 5th nerve and the 6th nerve. 6th nerve is always the nerve which I seek actively, because the damaging this nerve is very detrimental to the patient. So I always want to see the 6th nerve to preserve it properly. Then there is the trouble with the 4th nerve, because it's directly on the dorsal side of the tumor from where you are coming. And this is the most frequent complication of this surgery, that the 4th nerve is not preserved. Fortunately, the clinical consequences are really nearly negligible. I wouldn't say negligible, but small. Then we get below the superior cerebral artery, which is the medial aspect of the resection, and anterior. And once you release the superior cerebral artery, the biggest advantage of this approach is that you very early on see the interface between the brainstem and the tumor. And you very early on can decide whether the resection will be complete or whether you will leave some part of the tumor on the brainstem, which is not really that infrequent. And this is after we've cleaned the interpeduncular cistern. So this is the opposite side, posterior cerebral artery, opposite side, posterior clinoid process, pituitary stalk, and the opposite side, tractus opticus. It's better seen here. This is the optic tract and this is the pituitary stalk. And the same on ipsilateral side, posterior clinoid process, posterior cerebral artery, superior cerebral artery running towards us, and the third nerve, which is always between the two arteries. That's probably the only anatomical feature which is 100% constant. And looking medially, we see basilar artery, we see posterior cerebral artery and superior cerebral artery. And the shiny structure here is the Lillienquist membrane, which was the anterior border of the tumor. And this is the whole approach. Again, you see that the cerebral hemisphere itself by gravity gives you space enough. This is the V-shaped cut in the tentorium. And here is the post-op image. There is, of course, the remnant in the cavernous sinus, which we never attack, which we keep for radiosurgery or observation. Somewhat more complex tumor here, which was growing out from the superior petrosal sinus and posterior part of the cavernous sinus. A pity we do not have the video here, but this was done with the exoscope, and you would see the third nerve, you would see the interface between the brainstem and the tumor, and how the piece which is underneath the temporal lobe is evacuated. And this is after, again, of course, the remnants within the cavernous sinus left behind, but otherwise no problem. The main bulk of the tumor is resected, and this is a piece of the tumor which may be treated with radiosurgery. We do not use radiosurgery upfront. We always wait for tumor progression. This was nicely described in this article by a group of EANS skull base section, but there were not only EANS people. You see that beside us being from EANS, there is Goto, Ohata, Almefti, Fukushima, definitely not the members of the EANS, and it took some time to write this article, but it was really fun, and it gives you all the insight on petroclival meningioma. Going superior, very specific approach and very nice. You may approach the middle portion of the middle fossa. It's central regions by supra-infra. You see that it gives you rather wide space, and since it's quite far, you get a very wide side. So this is the cholesteatoma in this region after the surgery. Here is the meningioma. You see it on the left side, the lady is already having difficulties. There is edema all around the tumor. So whichever approach you would choose, you would have to retract the edematous brain, which we didn't. This is again the video. I think along the superior petrosal sinus and along the tentorium, resecting the tumor. This is after surgery, and you see that the supratentorial brain is completely untouched, and the lady is completely without any deficit and problems. Combination. In case the tumor is growing too low, you may use retrosic or even far lateral as a combination. Like in this case, you see the big petroclival meningioma with its origin rather low. Actually, the origin was between the 7th and 9th and 11th medially in prepontine system. This is after the surgery, which was radical. And I again cannot show you the video, but we started with supra-infra, resecting the upper part of the tumor, then with retrosic, resecting the tumor in the region of 7th, 8th nerve, and then going from below via something which is called far lateral in honor of Juha Hernesniemi, I call it enough lateral, resecting the condyle only modestly, and that was where we finally hit the tumor origin. Then combined with above with falcotentorial approach, the tumor which is in the rectus sinus, completely occluding the sinus, being above the tentorium, below the tentorium. In this case, to be able to resect all the dura, we started supratentorial along the falcotentorial angle. This is the part which is supratentorial, which was resected first. Then we went the same way on the opposite side, just to free the dura. The tumor was not out there, but to dissect the tentorium, the main bulk of the tumor was resected by supra-infra, which was opened below. And this is after the surgery, and you see that all the dura all around the tumor is excised. I did a mistake in this tumor because the only drainage from the deep venous system was via internal cerebral veins, which sent into the inferior sagittal sinus. And cutting the dura, I cut the inferior sagittal sinus, which was the only drainage. And then the postoperative core was, we call it stormy. It was difficult. The patient was like 2 months at the ICU. Finally, he managed, and he's doing well. So just to summarize it, the avenues you get by supra-infra tentorial approach, it's upper cerebral hemisphere and intracerebral lesions, which are in the upper part. I didn't show you any because it's so obvious and easy that it would not be up to date. Then tentorium and anterior rectus sinus. These are meningiomas and lesions in this region, but mostly, of course, meningiomas. Then pineal region with all the diseases in the pineal region and posterior third ventricle, upper posterior third ventricle. You do not reach below adhesio interthalamica because it doesn't allow you. But the upper posterior third ventricle is definitely excellent target. Of course, all dorsolateral mesencephalon, it means quadrigeminal plate and lateral aspects of mesencephalon along the ambient systems. Upper fourth ventricle, in rare instances where teloval approach would be probably too much and unnecessary with a little paravermian cerebellotomy. Then you read the posterior thalamus, provided the tentorium is opened, but it's not difficult. On the other hand, there may be venous lakes in the tentorium and the bleeding may be excessive. So it's better to check prior to cutting the tentorium whether there are not these venous lakes, which may be really nuisance. Then upper CP angle, all above 7th, 8th, petroclival region, posterior clinoid region, and above. And of course, you can approach by basal, medial, occipital, and especially temporal area for gliomas, epilepsy, whatever. So in my mind, this approach is very suitable for anything which is above the meatus. Actually, we have now the retrosic approach reserved for specific lesions in this region and for schwannomas, nothing else. Anything which is a little lower, we go from enough lateral approach. Anything which is above, we go from supracerebral infratentorial. If need be to get a little below meatus, there can the craniotomy should extend to the sigmoid sinus, and you can have a little excessive cut on the dura to the side, and thus you will get the exactly like a retrosic approach. So it's combination then with prevailing supra-infra. To take home message from this, it's very easy. Be flexible and inventive. Don't be dogmatic. Don't take the approaches described in the literature as a given. Use the one with which you are most comfortable with. And in this case, this is an easy surface craniotomy, which is done within 20-30 minutes. So no these petrosectomies and not these cavazes approach, these difficult things, which possible complications. Very straightforward approach, very complication-free. We didn't injure sinus like transfer or torcular in one case. In one case where it was a repeated surgery with all the, we injured the sinus, otherwise not. So in my mind, supracerebral infratentorial approach is something like pterional approach in posterior fossa, very suitable for anything. But of course, in many instances, do not forget other treatment modalities. We have radiosurgery, we have endovascular techniques, and all that. I would call your attention to these articles where there is something like a consensus on EA and scalp section. So The important one in this part is the petroclival meningiomas, but we have published clinodral and tuberculous meningiomas and few others as well. This is the summary. This article is a summary of the flexibility of extreme lateral. We call that extreme lateral, but it's a lateral approach going to the sigmoid sinus and along in this article. And the fact that it's suitable for human means that it's also suitable for animals. You see the tumor very similar to that one which I have shown you of that pregnant lady. This is the lateral aspect of the pons, the shiny dots are arachnoid, and this is the patient after the surgery. We've published even these docs in one of the articles. To make some allowed advertisement, I would call your attention to AVMs and cavernomas, which we have published in this spring a few years ago, and still some of the chapters are very up to date. Has made this Czechoslovakia. It doesn't exist anymore. It's only Czech Republic and Slovakia, and you see that Czech Republic is in the middle of Europe, surrounded by Poland, Germany, Austria, and former part of Czechoslovakia, which now is independent Slovakia. And this is my city, and this is although thank to you all for attention, and excuse me, please, that the videos didn't work, but I hope that you got the message even without the videos. Thank you very much.
Thank you, Vlad, and home of Kafka's.
Yeah.
Franz Kafka. Okay,
It's
one
not as
link
bad
to
as Miami. You know, this is much more beautiful than Miami. I'm sure of that.
Okay, but one link, could you host the questions, please?
Yes.
Yes, yeah. I saw there are quite a lot of questions from the audience, right? Are there any questions?
Professor Benes, this is Bing Shi
Yes.
from Shanghai.
Hello, Vin.
Yeah, thank you.
Good to see you again.
I just come up from Istanbul and just going home. So very nice presentation. And what kind of position you prefer to use SCIT? Because some neurosurgeons prefer to use semi-sitting position. What kind of your position you prefer?
What we use is a really sitting position as it was described originally. I know that in this semi-sitting you can get there easier as well, but what I use is the inclinations of the operating table. When we start, we incline the table forward as much as possible in order to get tentorium horizontally. And if you would do this with semi-sitting, and you will have to, otherwise you would have to sit on the floor going upwards, then you end up with actually sitting position anyway. And we really have a good anesthesiologist, so they monitor everything. We have a cardiologic evaluation before surgery, whether there is not foramen ovale apertum. Then they use the esophageal echo, which is monitored throughout the surgery. They have a screen and you have the terrain there, and they see any tiny bubble which would be there. So this is a good prevention. Then we lift the legs as much as possible. So we do all these preventive tricks, and I can tell you that sometimes they report that there are some bubbles on their screen, but never ever did we have to lower the position or quit surgery or something like that. But it's really not about us, it's about anesthesiologists, and then the sitting position is very useful. It's very comfortable, especially using the exoscope. You are just normally sitting there, working very comfortably. So I really love it. I have seen this approach in a prone position. It's nothing which would tempt me. Semi-sitting or sitting.
Okay, thank you.
Welcome.
Okay.
Professor Benes, do you use in some cases the supratentorial approach when the tentorium is very high and we can't go easy to the apex of to the vermis?
I see what you mean.
Yes.
This is the case if you go through the midline. Then it's very steep, and you really have to work above your head, like in a car repair shop. But going from lateral, from the side, the approach is not as steep. It's more horizontal. Then it's like that.
Yeah.
And you are not going to the very top. You are coming from the side. So really the inclination is much smaller. And if you tilt the table, you make it even better. In a way, the trick is to keep the tentorium horizontal or even inverse, and then use the stitches to lift dura. You lift even the rectus sinus, another 2-3 millimeters. If you open the tentorium, you can put the stitch into the edges of the tentorium and again use them as some retraction. And suddenly the space is opening, and you are still working in a horizontal way. You never ever need to go above your head. Okay. It's about the position and about the retraction of dura. Okay, and the side. Don't go through the midline.
Okay, thank you very much.
Midline is terrible.
It's important for me.
Going from the midline, you must cut all the veins coming from the upper vermis. This way, there is in the way 1 or 2 tiny veins coming from the surface of the cerebellum into the tentorium. It's better to coagulate them and cut, because if you tear them out of the tentorium, you get the bleeding, which is very difficult to manage and which really is nuisance.
Thank you.
Thank you.
With this approach, can you access to the tumor in some cases that are rare, but in some cases we can have glioma in the superior vermis, like the anterior part, and it's very hard to get it from.
You can get there. You get the border of the tumor anteriorly and superiorly is usually corpus callosum. If you cut the tentorium and you resect the part of the tumor which is on the side, suddenly you see a whitish structure which is corpus callosum, and you really get as far as the genu of corpus callosum as it's going down. So you can get there, but I would say that we are not doing this for high-grade gliomas. High-grade gliomas, it's really frustrating because you did see the patient in several months with the relapsing disease. So we keep it for low-grade pilocytics and these kind of the lesions. We do high-grade gliomas, we just leave to oncologists in this region.
Okay, thank you very much.
Thank you very much.
Professor Benes, I noticed your bone window, some part of it is upper side of the transverse sinus. So would you use it sometimes? Use the upper side of the transverse sinus during incision?
You mean like falcotentorial route?
No. You do this SCIT creotomy. Some part of the was the upside of the transverse sinus. So do you use sometimes the upper side part of the duromet?
I know what you mean. The craniotomy always is above the transverse sinus. Always take care to cut the bone above the transverse sinus, and only very rarely do we need to go even supratentorial above the sinus. It's in a rare meningiomas where they have extension there, and as the experience increases, we are using it very, very rare. You know, I remember one case lately. So everything can be done from below. And the trick really is to lift even the sinus a bit by stitches. You really get another millimeters, which gives you ample space.
Okay.
Always, of course, when you hit the sinuses, and it's always important, I always check the transverse sinuses on both sides. And if there is a selection, if it's medial lesion, then I go from that which is higher and which is less significant. Most frequently, the sinuses are not at the same level. One is higher, the other is lower. So going from that side where there is a higher rectus transverse sinus.
Okay, thank you.
You're welcome.
Excuse me, there's one question from Harshad Parekh, a neurosurgeon from Mumbai. He said, which lesions of the thalamus do you feel better to approach by this approach?
That's a good question. I wouldn't go for high-grade glioma. Otherwise, almost any. And the most frequent and the best are, of course, cavernomas. And the second are low-grade gliomas, like pilocytic astrocytomas and low-grade gliomas. These two types of lesions in the posterior thalamus are the best suited for this approach.
Okay, when do you decide to approach contralaterally?
Yeah, that's what Michael Lawton has described for cavernomas. He goes contralaterally. I don't think it's necessary and reasonable, because you have to part the big veins if you go to the opposite side. They are a little bit on the side, but still they are there. And there is always a trajectory which is directly from ipsilateral side. So I haven't done a single approach to go contralateral, despite the fact that I love this contralateral approach in suprastellar approach. In this case, ipsilateral is always better, easier,
Okay.
and shorter.
Okay, thank you, Vlad. Ben, do you want to move on to the next speaker?
Yes, Professor Benes, thank you again.
Thank you very much for inviting me, and it was really a pleasure and honored to be here. And sorry for the videos. Next time. Thank you.
Thank you. So now let's welcome the next speaker, Professor Zhang Xiaobiao. He is the chief of the Zhongshan Hospital, Fudan University. Professor Zhang.
Thank you, professors. Good evening. Thank professors. Thank you, Chiping.
Yes, if you want, can you put it in full mode, full presentation mode, please? Perfect. Okay.
Are you found?
Perfect.
Ladies and gentlemen, my lecture is about endoscopic bilateral theta approaches for petroclival meningioma. Is our hospital. As professors Sinis see, the theta approach can do many operations. The theta approach may classified midline, perimedial, and far lateral approaches. These approaches can do many operations, such as pineal region tumors, thalamus tumors, meningiomas, and many other tumors. First, we simply introduce the midline theta approaches. This is our position. This is pineal tumors have doing twice of operations of VP shunting and gamma knife, but the tumor become large, and we use this midline approaches to resect the tumor. We only open the right side of the cistern. dissect the tumor from brainstem. Tumor being removed from the right side. You can see abduct is duct. Tumor being removed. We can also use this beta theta approaches to resect tumor in the thymus. This is thymus. We open the left side of the system and expose the tumor. This is cavernous sinus malformations. We use the midline approaches, but we do this operation from right side to left. Only open the left side system. We dissect the tumor. Tumor being removed, put into the surgical. Tumor being removed. Next is another tumor. This is glioma. We also use this midline approaches from right to left. We dissect the vein. We only open the left side system. You can see the tumor.
Yeah.
The tumor is very soft. We can use suction to resect the tumor. Sometimes the glioma in the thymus is very hard. We use CUSA to resect the tumor. This case is very soft. We only use suction to resect the tumor. This typical suction can resect the tumor in the lateral side. Tumor be removed. we can open the pseudoventricle and see the structure of the pseudoventricle. This is the follics. Then we use surgical to stage. Of the tumor being removed, but the pathology is glioblastoma is unfortunate. Next, we introduce the perimedial theta approaches. This operation position is similar like this midline approaches. This is a pioneer region. They have AFP, beta HCG are high. We first use the ETB to treatment of the hydrocephalus. The tumor are being large. Tumors are very large. We use left side approaches. We write the left side system. We use the mini retractor to help expose the tumor. This is a drain veining, this sublime artery. We first cut the artery, and then we dissect the draining vein and cut. This is another vein. This is a small artery. This is tector artery, a tector vein. Then we dissect the tumor from the brainstem. The right side supply, we put out the tumor. The tumor have 5 kinds of pathology. The AFP beta HCG abnormal. There are 5 kinds of pathology. Tumor be removed. Next, we introduce the we sometimes the tumor is a pathology. It not exposed from the middle side. We use control lecture to expose the tumor. If the tumor be located in this part, this is the tumor. The tumor we from the left side. We open the left side cistern. This is right side thymus. We cut the thymus and then expose the tumor. This is a cistern. This is a solid part. we use CUSA to resect the tumor. Of the tumor being removed, there's no bleeding. We use surgical fluid to hemostage. This is a pseudoventricle. This polycytic astral system. This another case is cavernosus sinus malformation. We also use contralateral side. We from left side to expose the pineal gland. We display the pineal gland and into the pseudoventricle. You can see yellow part of the cinemas. We cut the right cinemas. And expose the malformation. For the tumor being removed, we also use the surgical fluid. And the surgical. Tumor being removed, the MR. Our paper. This is our paper. Today, we talk about the far lateral approaches of far lateral theta approaches. In our department, this approach can do many operations, such as Pedro Canaiva, meningioma, trigeminal schwannoma, and epidermoid system, and hypothalamus hematoma, and cerebellar hemangioblastoma, and glioma and of brainstem, and cavernous malformations of brainstem. Sometimes we also use EGV from outside of the pseudoventricle to uterus side pseudoventricle. This is minimally invasive because we do to resect the tumor with the hydrocephalus. We do these operations. This is hemangioblastoma. We use these approaches. It will be removed. This is CPA. We do operation of trigeminal schwannoma. Can also use these approaches. This is trigeminal schwannoma. Some case you can see. This case is a large dumbbell trigeminal schwannoma. Sometimes we use transnasal approaches or Kawas approaches to resect tumor. But no, we use this far lateral approaches is very minimally invasive. You can see this tumor been removed, and the patient recovered and have good normal life and work. Another case, this is large tumors. You can see we use these approaches may protect the normal structures in the posterior skull base. This is important structures, so we use these approaches very safe. But if we use the transnasal approaches, what we finally we find these approaches, we pull out the tumor. It is very dangerous. The tumor been removed, the patient have recovered and have good life. This is our paper. Sometimes we can use these approaches to craniopharyngeal tumor. As you know, you can see this picture. This is you can see this is the floor of the third ventricle. This is a mammillary body. This is the stalk. Sometimes craniopharyngeal may located in this site. If do this operation, this site of operation, we can use we can use LSO from use LSO to resect the tumor. Use second space to resect tumor between the ICA and optic lobe. We may use we may use transnasal approaches to resect tumor. We can cut the posterior clinoid process and dorsal sena and display the pituitary gland to expose the tumor. But this we use far lateral theta approaches minimally invasive. You can see this is this space may very large. This is a case with 2 craniopharyngeal tumor and have suffered 5 times operations for the tumor in CPA. Use radiosigmoid approaches, but the tumor also recurrent. So we know use these approaches from far lateral theta approaches to first resect the tumor in the CPA. Then we found the tumor can easily to use these approaches to expose and resect. The patient have recovered and graded from school and have walked. Is our paper. As you know, there are many approaches to expose and resect the tumor in the peritoneal region. But in these operations, we retrosigmoid approach and the coarse approaches may minimally invasive approaches. But no, we found far lateral theta approaches also minimally invasive approaches to this region. Far lateral theta approaches is different from retrosigmoid approaches. You can see this is from the intro tentary approaches to expose the region. You can see our anatomy study, retrosigmoid approaches can expose this region, and coarse approaches can expose this yellow region or red region. But the far lateral theta approach can expose upper clivus and is very large. In the endoscopic is more large to the contralateral. We use this approach can expose the petroclivus region, and we also see upclivus region. This is a pituitary stalk. This is ICA, PCA, SCA. This is a small mini tumor of this part. You can see we expose from these approaches. We do these approaches is very challenging and have many key operative techniques. We want to use CSF training for relaxing of the cerebellum, and it is create the space of operations. Next is operative position. And during the resected tumor, we may use CUSA to ensure capsular debugging, and then we can medical use dissection. In the operation, we may use electro physiological monitoring to protect the normal structures. Sales training is very important. We sometimes use a number puncture to training the CSF. Sometimes we use a CM system to training the CSF. This bilateral approaches different from middle line approaches and perimedian approaches. You can see we can rotate the head back and lift it up through the cerebellum gravely moved back and down from tentorial and petrol bone, and create the manipulated space. This operative position is very safe and no air embolism, and surgeon will very feel comfortable. To these operations have very difficulties. First, the blocking of 5 level and SPV, the blocking of our vision. The two large mini tumor dissect of the night. Large mini tumor from the normal structure is very difficult, and the tumor involved such as involved adjacent areas such as cavernous sinus and Maker's cave, and other side is the mid cranial base. You can see is the anatomy of the these approaches. These 5 nerve and SPV keep blocking. This is the SPV and 5 nerve. But in a small tumor, this is a problem. But to large tumor, sometimes the the 5 nerve may be displayed from the normal side, often to the under the tumor or the lateral of the tumor, but the SPV may be cut. But to the small tumor, this is a small tumor. You can to do this to resect the tumor from between the nerves and veins, vessels. You can from a different space. Pre-operative imaging analysis is very important. It can tell us normal structures such as artery and vein and artery and the nerves and the SPV. And sometimes important to know the basin artery and VA. This is 5 nerve. This is artery. This is artery. The T2 MR high signal of the brainstem can tell us the edema of the brainstem during operation. Where we must carefully to dissect the tumor from the brainstem. This case, the edema of the brainstem. How to dissect the tumor from the brainstem? We like to pull the tumor away from the brainstem. Don't dissect between this tumor and the brainstem. This case, we pull the after the intracapsular debugging, we pull away the tumor from the brainstem. If the tumor involved of the middle skull case, sometimes in the maker's cave and cavernous sinus, it is very challenging. This posterior view of the intermediate triangle of the cavernous sinus. This is anatomy of the ICE. This is a middle skull case. This maker's cave. This tumor, we use this approach. We totally remove the tumor. You can see the tumor involved in the maker's cave. After the large part of the tumor being removed, we dissect the tumor in the cavernous sinus maker's cave.
Hola, Glo.
Tumors in this cave be easily be dissected and pour out.
Estaba viendo el video del seminario Empezó a las 6. No sé.
No defensive.
No he hecho ruido, estaba bien en el cuarto. Pues ahorita salí.
Then we use you can see the tumor be removed.
No he salido. No, para no hacer ruido.
Some typical cases. This is 37 ladies with petroclival meningioma. You can see after tumor be removed, the patient have a good result. Another case,
Okay.
this case with a headache, right hearing loss. The blood is very rich.
Son
The tumor be
gigantes.
removed.
Bueno, yo no los veo ya ahora, ¿no?
This case, the tumor involved of the scorpius.
Por eso es que veía yo antes.
Middle scorpius is a cavernous sinus. The tumor be removed.
Pues lo levanté porque me acuerdo que hoy es la carrera esa que Rodrigo ve.
This another case.
Voy a poner a ver si se ve la
This
tele.
be removed. This case, the tumor being very new in the new clivus. This is very difficult. You can see this is right side.
Con este.
If the tumor be removed, you can see basal artery and the VA. This is normal structures are being kept. Totally removed.
John, can you please unmute the others?
Excuse me?
There are some participants that they talk. Can you unmute all the participants, please?
No, I can't unmute anybody. They have to unmute themselves. You have to unmute yourselves.
No, not unmute, mute.
Oh, mute.
Mute,
Yes.
mute. Yes, sir. Mute.
Something she previous she. This
Yeah,
is a
Please go on.
this next case. This case is of tentorial type of petroclivus. You can see the involved tentorial tumor, 4 nerves, tentorial. The tumor be removed. Patient have hemiplegia of right nimble after operation, but recovered after 6 months later. So we see the video. This is the left side. This is SPV. With CUSA debugging, we dissect the tumor. We pull the tumor away from normal structures, especially the brainstem. Then we continue to cut the tumor. This is the brainstem. We pull away. Pull away the tumor and carefully dissect. This is a 5 nerve. We use pituitary rear to resect the tumor. We use polar coagulation to cut the tentorial. This is a fourth nerve. This is a third nerve. The tumor be removed. We check the normal structures. We look for the sixth nerve. Can you see these 6 nerve? All normal structures being protect this SPV. This is other nerve. Tumor be totally removed and have the result. This is another case. You can see we use normal coagulate to dissect the tentorial. We dissect the tumor from the artery. We continue to use CUSA to ensure capsular debugging. Then we dissect the tumor. The SPV, you can see the 5 nerve, the maker's cable. We use tip curve bipolar dissection, bipolar coagulation. The brainstem tumor being removed. Which this 2 weeks we do the operation. Just 2 weeks. This maker's cable. Many. This tumor, SPV. Pull the tumor away from the brainstem is very important. The trigeminal nerve. Pull away the tumor from trigeminal nerve and dissect the. We coagulate. We cut the tentorial to pull down the tumor up the tentorial. This is stalk. We cut this tumor in the maker cable. can easily pull out. Tumor be removed. Non-structures be protected as PV. Trigeminal nerve. Patient 1 week after operations, the patient have good result. This is our paper. Conclusion: endoscopic far lateral theta approaches is natural surgical approaches for many nations and deserve for further structures. Thank you very much.
Thank you, Professor Chang. Very nice presentation. And I noticed that some tumor are out of your direct surgical field. So you demonstrated that you just pull it out. So
Yes.
how do you make sure you already totally remove the tumor? Do you do some intraoperative MRI or some endovascular further observe to make sure the totally remove of the tumor?
In the past, some cases we use MRI to check the tumor. But this case, this final case is only 2 weeks.
So I noticed that you never use drill to drill off the bony structures. You preserve all the bony structures.
Sometimes we use CUSA to recycle the bone of the cerebral meatal tubercle to expose the cavernous macro cave, like the SAMI, Professor SAMI. But no, I found it isn't not necessary. We use the endoscope deepening can found out very easy.
Okay, thank you.
Thank you.
Professor Benes, do you have some comment or questions?
I like that very much. It was really extraordinary use of endoscope. We are using them only to check, the same thing you are using endoscope from the very beginning. We introduce the endoscope only when we do not see behind the corner, when you need to see, let's say, into the macro cave or places like that. So it's endoscope assisted. But pure endoscopic approach for such formidable lesions, it's really extraordinary and perfect. I'm still think that by open approach, you get more flexibility and you can dissect the tissues better. You do not need to coagulate all those vessels. So it's still a question of development. But thank you for excellent lecture.
Thank you, Benes. So Professor Chang, he always performs pure endovascular endoscopic surgery.
We do all operations to use pure endoscope, like the aneurysm and malformation, many kind of operations. But in the past we also use the microscope. In our department, young doctors can also use endoscope. They don't like microscope.
Thank you. Professor Zhao Yuanli.
Yeah, I know
Yeah.
Professor Zhang did a lot of surgery with endoscope and with excellent outcome. Yeah. So, Professor Zhang, what about your opinion for, the new exoscope? Is that okay? I mean, like the new new type Kenevo exoscope or the arrows from Esculap. The 外视镜现在the new
extra scope, like a microscope, but it is a simple microscope, not like endoscope. I don't like the extra scope.
Okay, so in your department, you almost do every surgery only with endoscope, right?
All operations we use endoscope.
Okay, thank you.
Thank you.
Okay, thank you.
Thank you.
So, John? Hello, John?
Yes.
Yeah,
Okay.
yeah.
Do you want to wrap it up, Ben? Yeah, does anybody have any more questions or comments before we close? Okay, a very interactive session, Ben. Thank you very much, Vlad. Thanks, Dr. Ben, for organizing it, and Juan Lee, as well as Dr. Zhang for giving 2 great presentations. And so we're going to see you guys in 2 weeks.
Okay, thank you.
Okay, thanks, everybody.
Thank you, John.